So we're having a chance to talk to another one of the Kinetic Control tutor team, and today it's Koen, Koen Schoolmeesters. Is that correct, Koen?
Yeah, that's almost correct. Yeah.
That's almost correct. Okay. Thank you very much.
It's the typical Dutch Flemish name, so not easy.
Okay, so how would you say if I said it correctly?
It's just Koen.
Okay.
Koen, yeah.
And Schoolmeesters?
Yeah, it's actually Schoolmaster. It's almost the same. Yeah.
So it's a perfect name for a Kinetic Control tutor, deliverer of education. So that's great. Okay, so we're having a chance to do another one of these podcasts with the tutor team, and today we're going to explore a little bit of your sort of history, your sort of perspectives, and where you're going next in terms of delivery of KC courses. So I'm going to sort of start with a little bit about yourself, where you're based right now, and what you're sort of getting up to sort of clinically. So where are you based?
I'm based in Belgium, in the center of Belgium, near to Brussels, and it's actually in Leuven, in Louvain.
Okay, perfect.
Yeah.
And clinically, what are you doing clinically now in terms of hours and other things that you get up to?
Yes, clinically, I think at this moment, I think I do 90% of my time clinical work in my clinic with other colleagues. And our clinic is especially focused on musculoskeletal rehabilitation, also some pediatric rehabilitation, pelvic floor also, and ödem therapy. But especially musculoskeletal system, that's our main business, I should say.
Okay. And the other 10% of the time, you mentioned 9% of the time was sort of clinical.
And the other 10% of my professional time I spend to teach for Kinetic Control or at university in Leuven.
Excellent. Okay.
Yeah.
So then I'm going to wind all the way back. So that's sort of where we are now, but I'm going to take it back to sort of why did you become a physio in the first place? So what attracted you to doing that?
Yeah, maybe as child I was attracted by human body in some way, but also I like to do a lot of sports and movement, and I think this combination was for me the decision to study physiotherapy. But actually, firstly, I did physical education. It's I had my master degree of physical education in '88. And then I continued with physiotherapy and also sports physiotherapy. So in '91, I completed my degrees as physical education physio and sports physio.
So the thoughts I'm now having as we're thinking about sort of you've come down those sort of two different routes. I mean, they're complementary, but they're different. And also what was being delivered in say 1988 and what was being delivered in 1991. If you just took a bit of a sort of perspective on how different or what is the same and what's delivered now, because you mentioned you're sort of teaching at university. How different was that course in 91 to what you sort of deliver maybe within 2023?
Oh, it's a big difference because physio is a very young profession, and when I studied physical education and physiotherapy, the curriculum was almost the same. But now, since more years, it are really two separated faculties actually. Before they were blended or mixed together, but now they're really two independent faculties. So there's a lot of evolution passed or done in the physiotherapy. It's a huge difference. Yeah.
Wow.
Yeah. That's why we also needed to do a lot of an extensive program of lifelong learning courses and other courses to become a better physio.
I see. So again, there'll be a fair amount of physios that did come through those courses in the 90s, and we're saying there as well that the education has changed a lot since then. So that's when there's opportunity to doing other CPD type activities. I mean, for example, we talk about Kinetic Control, but there's lots of other stuff out there as well. if there were a couple of again key differences in content from 91 to what you do now, what would you sort of see the differences being? What would be the key differences?
Yeah, yeah, for sure. At that moment, we were especially focused more on the joints. It was more an articular period, I should say. There was not much interest in exercises in muscles, not at all in psychosocial features. So it was especially focused on the joints at that moment. And during all the years, there was an evolution from manual therapy and joints to more movement control and movement retraining, movement control, and also more and more also to the psychosocial features. So
Yeah.
there's indeed a big evolution during all those years.
So we've moved out from the sort of articulations now into a more embracive approach with the whole of the body, but also that the social features, the sort of more the mind being involved as well as the body.
Yeah.
Okay. So a big change then in those sort of 30 years.
Yeah.
Okay.
Yeah.
Wow. Yeah. So you then went into working clinically. So having completed those degrees and masters, you then went into working clinically. So what was that first what were those first clinical roles? Where were you working first?
So when I finished university, I expanded my knowledge by extensive program of musculoskeletal courses. And at that moment, it were courses like Syrax course, Mackenzie course, courses concerning articular mobilizations. There was also courses concerning urodynamic features. It was on Bob Elvey was coming to Belgium. So I did a lot of courses after my my master degree. But then in 2000, I did my first Kinetic Control course. And yeah, that was a real big difference for me. It was a big difference for me to compare to the other courses. It gave me a lot of a better view, a better way of clinical reasoning as before.
So just to get the context then, so you sort of you're coming out of academia as a student of in the 90s, then you're continuing with different CPD activities, and then somewhere along the line you get introduced to Kinetic Control. What year, can you recall what year was that first KC course you did?
The first KC course in Belgium was a course I did. It was a course in 2000, I think.
Okay.
It was Sarah Mottram who came to Belgium for the first time. And it was a course of 5 days. So it was a very intensive course. And it was at that period, Sarah taught 2 theoretical concept days, followed by 3 days concerning lumbar course. So it was a 5 days course, and yeah, it was really eye-opening for me to do this course, and that's why I became interested in Kinetic Control concept and Kinetic Control.
So in 2000, so we're taking it back, wow, 23 years to that first exposure to Kinetic Control, and then started applying that clinically. What was the point you thought, I want to start getting involved in delivery of this, of education for teaching for Kinetic Control? So when did that start to come about? You're starting to think, I might get involved as a tutor.
Yeah, it took for me different years, because at the beginning it was a lot of new stuff for me, and I was especially interested in learn everything about Kinetic Control, but teaching that was not my first objective. But I was especially surprised by the structured way Kinetic Control used in its clinical reasoning model. So the structured assessment, a good interpretation of the test, also a structured rehabilitation, and also that the Kinetic Control concept looked to me very open-minded. So I did already a lot of courses, but it was allowed to implement all the things I already learned and did and used with success, to implement them into the Kinetic Control model, and that was very interesting for me, that it was a real eclectic system to use.
That's I think externally, if you're seeing Kinetic Control for the first time, you might think it's all just about the testing, or they're about retraining exercises, however you want to sort of phrase those things. But actually, what I see it as is very much a framework, which then allows clinicians to employ their skills within that framework, but it gives a reason for why they might use them and when they might use them. So I think that has been a real strength of it. So I'd say Kinetic Control is much more of a framework than just it's about testing or about any particular one component apart from that framework, which you can then build things inside of. So that's I recognize that, and I can see why clinicians really value that component of it.
Also the link between the Kinetic Control courses and manual therapy, that was also for me something new. That it was a good marriage between stabilization work of movement, coordination, retraining, and manual therapy. And that's every day I still use both as well, manual therapy as also the movement coordination, retraining strategies. So there's a good combination. That was also very new for me at that moment in 2000.
So really positive, positive experience in terms of Kinetic Control and what this could do, and also its accepting of other approaches within it, other techniques, let's say. And then when was the time you started to think, okay, now I'm interested in starting to teach KC courses?
Yeah, I think it was 2003, I think. So when other tutors came to Belgium, I was always there to help them and to assist them. And then in 2003, I decided, okay, it's that interesting that I'll do a lot of efforts to become tutor. And then I started my Kinetic Control training program. And it took, I think, 3 years before I did my exam. So since 2006, I'm accredited Kinetic Control tutor. Yeah.
I mean, that's nice because it gives you also the extent of commitment to becoming a tutor. So although, I mean, if we just sort of wind this back, since 1991, you've done two routes of education, physical education, plus you've also done physiotherapy. You've got extensive clinical mileage by 2003, and you've been exposed to KC in 2000. And it's only in 2006 that you get to that point of being accredited as a tutor after a 3-year long development program. So sort of hopefully identify there's a lot of development work to do to become a tutor. I think it really sort of reinforces that, even with somebody that experience, with that background education as well, that becoming a KC tutor wasn't simply wasn't done in weeks, wasn't done in months even. So very impressive.
Yeah, indeed.
So 2006, you're now an accredited tutor. How was your first teaching experience for KC then?
I think during the training program, I teach already together with other tutors. So I learned already a lot how to teach, the way to teach. The content was also quite good, familiar for me. So yeah, it was for sure a process. You have to evolve in teaching, and at that moment I could teach a lot of courses in the Netherlands, and yeah, so it was very nice. It was very amusing, and I liked it very much to teach there. Yeah.
Okay, I'm pleased that you could sort of get the KC clinical framework in there alongside some humor as well. That's always helping I think, with the teaching to make sure that people are engaged and relaxed and can enjoy the content rather than being sort of too super serious. So that's I appreciate that. Now, you've developed some real sort of clinical expertise, which has allowed you then to deliver some of our more level 3, as they used to be called, or masterclass series. So which masterclasses can you deliver?
I like especially the thoracic outlet masterclass. It's not really it's more cervical thoracic impairments. It's about minor thoracic outlet symptoms. The SIJ course is also level 3 one, and lower limb, that's also level 3. So that are the ones. And myofascial trigger points is also one I use to teach. So these are the level 3 courses. Yeah.
And was it the case that you already had those skills you'd acquired along the route has been over your sort of clinical mileage, or was it the case you saw those masterclasses delivered, going, I'm going to attend those, I've attended them now, I'm now going to start thinking about becoming a tutor for those? So is that the evolution? Is that how it happened?
Yeah, actually it is. Firstly, I did a lot of level 1, 2 courses, but then I evolved to teach also the level 3 courses, and it's more linked to the real clinical work I do every day. So it's a combination of also other approaches. It's retraining movement coordination strategies, but it's also mobilization of a joint, something about new dynamics. So it's a real integrated course that you can for sure use next day in your clinic. So the content is very, very clinical relevant.
That's the again, that application that tomorrow you can use this is a big part of, again, the KC delivery framework. That's what's in the course has real relevance for what's coming next week for that clinician who's been on the course. So that's always been key to keep that clinical relevance all the time. Okay. So 4 really sort of nice meaty masterclasses that you can deliver. With respect to Kinetic Control, then, have you had a chance to sort of deliver these across the world, sort of traveling and teaching?
Yes, indeed. At the beginning, I was especially teaching in the Netherlands because there was no other Dutch-speaking tutor in the Netherlands. So I did most of my courses, I think, in the Netherlands at the beginning. But then when there was also another Dutch tutor in the Netherlands, I was teaching in Belgium in my clinic, actually. But also on some congresses and other venues, I teach also in Belgium. And after that, I did also a lot of series of courses in Cairo, in Egypt, and some in UK. Yeah.
Perfect. And we're thinking about getting you back in the UK soon, some delivery of those masterclasses as well. So that would be great. So hopefully we can start getting that going again after the past few years when it's been so difficult to travel and have face-to-face courses. So that would be really great if we can.
Yes.
Okay.
Indeed, yeah.
So just then sort of looking at the future a little bit now, with your extensive experience as a physio and extensive experience with Kinetic Control, also your involvements with the university there in Louvain, where do you think sort of, I guess, this movement approach, the clinical reasoning framework within KC, where do you think this is going over the next 5 years? What do you think sort of physio is going to look like with respect to sort of movement-based testing, retraining interventions? Where do you think this is going to be heading over the next sort of few years?
Yeah, so there was already a huge evolution. Kinetic Control is also evolving enormously. When we look back 20 years, a lot of things are changed, a lot of emphasis are changed, a lot of focuses are changed. I think that the strength is still that the that the kinetic control concept allows to make an additional diagnosis, not only a medical anatomical diagnosis, but also diagnosis in terms of movement patterns, movement coordination strategies. And I think the strength is also that these movement coordination strategies are linked to movement health, to quality of life. And I think this will be more and more important in the future. I think society is aware of the wealth of movement health, of quality of life. So I think the movement coordination strategies and the way of moving, the choices we have to move will stay for sure very, very important. So I think also the movement coordination tests will keep very important. And I think there will also be a little bit more focus on the psychosocial inputs. Kinetic Control is also thinking from the biomedical psychosocial model. And I think in the next years, the psychosocial model will be more important than before. So the combination of all those things makes Kinetic Control very, very interesting, because it's really a multifactorial clinical way of reasoning.
So an extensive journey there from that sort of late 90s, 1991 to where we are now in terms of your own sort of clinical journey, but also where you think this is going next with respect to the value of movement, the interaction with quality of life, and this concept we talk about in terms of movement health. And for physios, for clinicians, if you're going to just say, and you've said a lot already, but if you're going to sort of say there's one thing about why they might want to get involved with Kinetic Control, what would that be? If you're going to say one thing?
Yeah, one thing is quite difficult, because there are more things to consider.
Sorry about
that. But I think it's a multifactorial approach, and in every topic they are very detailed and to the point. They are specialists in all the elements of the multifactorial system. I mean, if we talk about global muscles, muscle synergies, they know everything about it. When we talk about the local muscles, the same. When we talk about movement retraining, so they're very, very specialized in a lot of, in all the subsystems and all the components that are important in the multifactorial system.
So it's that comprehensive approach, and as you're saying, multifactorial, and certainly where the things are going in terms of across the board, we're seeing much more appreciation of all the way back. We started talking about just the joint, and now it's much bigger than that. We're focusing on the whole person, including how they move. And I guess we've placed a specific focus on how people move as a sort of a marker of their sort of health and moving forwards. Okay, perfect. Well, thanks for your time and answering these questions, and for sharing your sort of extensive experience with us. It's great to hear after 20 years you're so sort of still passionate and keen on this model, on this framework, and still applying it clinically as well on a daily basis. So I think that's great to hear, and hopefully we'll get you back teaching in the UK soon, and hopefully elsewhere in the world as well, sort of, and especially in those master classes. It'd be great to share your sort of expertise around those different master classes you mentioned there. So we will do that. So thanks for your time in terms of doing the Tutor podcast today, and we will see you again on another time.
Okay, thank you, Lincoln. It was my pleasure to do this podcast.
Great stuff. So thank you ever so much.